So with that, I'm going to turn to our first speaker, Chris Jones.
Thank you very much. And thank you for having me here today. And I want to very briefly provide some context and trend data around the opioid epidemic and hopefully set up our final three speakers today. So this map compares county-level drug overdose death rates in 2000 compared to 2015. And you see that the rates are essentially held the same. And I think what's really the takeaway from this slide is that there's a lot less blue and green, which are lower overdose death rates, and a whole lot more orange and red that ensued over the 15 years between 2000 and 2015. And you can see here there certainly is variation across the country. In particular, in the Appalachian areas and in the Southwest, you tend to see much more red and orange. And sort of in the middle of the country, you still do see a fair amount of blue and green. But really, all areas of the country have been impacted. And I'll show a slide in a minute that compares the opioid issue that we're dealing with today to prior drug crises. But I think a couple of points are worth making from the start. So first, the opioid epidemic is much greater magnitude than we've seen before with other, say, heroin in the 70s, crack cocaine in the late 80s, early 90s. Just the magnitude of the issue is much broader. It's been more sustained, so this is looking 2000 to 2015, but we see the origins of the epidemic starting in the mid to late 1990s. And although there's been some evolution of what drugs are being abused, what drugs are being found in overdose decedents, it's all connected to the overarching opioid issue. It's also more geographically diffused. So we see areas in the country, more suburban and rural areas, that have been particularly hard hit, which were somewhat spared from prior epidemics of drug abuse in the United States. And again, as this county map shows, it really has broadly affected the country, certainly some more than others. And similarly, on a socioeconomic perspective, we really see across all socioeconomic status impact, whether that be economics or it be race, ethnicity. We see largely every category has been impacted, of course, some more than others. But it does represent something different than what we've seen prior to the opioid epidemic. And then finally, there's the iatrogenic component, which essentially stemming from changes in prescribing, we expose a larger number of people to an addictive substance. And now we are suffering the consequences of doing that. And I think it's also a positive thing that there's an iatrogenic component, which means that we have additional levers to address the problem. But we have to appreciate how changes in behavior within the health system and among healthcare providers have contributed to the issue. So as I mentioned, the opioid epidemic is more sustained, much greater in magnitude. So this looks at overdose death rates. The blue line are all drug overdose deaths. The red line represents opioid-involved overdoses, so that's prescription or illicit. And we look back to 1970 through 2015. And you can see here heroin in the mid to late 1970s, you get about 4 per 100,000 deaths. For cocaine, it's slightly higher, and it's a little bit more sustained period of time. But when we get to the opioids, as I mentioned, really starting in the mid to late 1990s, we see just a dramatic increase. And even in the last couple of years, we've seen a sharper increase in the rate. And I'll talk a little bit about that in a moment. I'll just say a limitation of some of our data sources is that prior to 1999, we were not able to distinguish certain classes of drugs. So cocaine and narcotics were all lumped together in the prior coding system. So that's why you see in 1999, we were able to break out opioid-related overdoses, and you can see that tracks very closely with the overall drug overdose death rate. And the situation continues to evolve. This is quarterly estimates of data from CDC's National Center for Health Statistics, looking at different subtypes of opioids as well as cocaine and psychostimulants with abuse potential, largely methamphetamine, and looks at it monthly over time through February of 2017. So final mortality data for 2016 are not yet out. So 2016 and 2017 data are provisional. But as Peggy said, we estimate about at least 64,000 deaths in 2016, which is substantially greater than the 52,000 that we saw in 2015. But you can see here, and a pointer would be helpful, but I'll try to navigate you through the busy slide. The solid blue line represents synthetic opioids. So that is largely illicit fentanyl and fentanyl analogs like carfentanil, phenylfentanyl, that are showing up in our drug supply. Starting really about 2013, we started to see this in the northeastern part of the US, largely mixed in with heroin. Now we're seeing that it is the drug of availability, not so much heroin in certain areas of the country. And you can see the really rapid increase in mortality involving synthetic opioids, about a tripling between 2013 and 2015. Clearly, the 2016 data, as outlined here, do not look encouraging. At the same time, we have seen a consistent but less steep increase in heroin-related deaths, and that's largely been since about 2010. And since about 2011, we've seen some stabilization in opioid deaths involving commonly prescribed prescription opioids, so your hydrocodone, oxycodone. And that matches pretty closely with changes in prescribing behaviors. We've seen sort of a stabilization in opioid prescribing and some decline in the last couple of years. And the bottom line, the bottom blue dotted line, is for methadone, where it's actually a slight decline in methadone-related deaths over the same time period. And I'll just point out the red and green lines are cocaine is green and psychostimulants are red, and you'll see that they're increasing in the last about 14 months in particular in this particular graph. I think an important point there is that those are largely deaths that also involve synthetic opioids. So we see some mixing in the drug supply. We did a paper earlier this year looking at cocaine-related deaths, and virtually all of the deaths involving cocaine that have increased in the last several years have been where synthetic opioids or heroin were also involved. So one, there's mixing in the drug supply, but I also think it represents the fact that although we're talking about opioids, it's really a polysubstance issue, and fundamentally it's a substance abuse issue, and just important to note that. Other aspects of the issue, so we talk about mortality, we talk about the number of people who are addicted. I think really what we've seen, again, sort of this breadth of the opioid issue, is that regardless of where you might practice medicine, you're probably being touched in some way by the opioid issue. So this just looks at a couple of different trends. The first is neonatal abstinence syndrome, and you can see here, both in urban and rural areas. Urban is the darker line, rural areas are the darker line, urban is the orange line. We've seen significant increases in neonates born physically dependent on opioids in the last decade. We had the largest HIV outbreak in Scott County, Indiana, over 200 HIV cases in 2015. Over 90% of those were co-infected with hepatitis C. We've seen a decade-long rise in hepatitis C rates, largely among people under the age of 30 and people who are living in suburban and rural areas. So again, for the magnitude of the issue, the geographic diffuseness of the issue is represented there. And then lastly, again, as I said, we start to see populations who are not necessarily seeking out heroin or fentanyl who are being exposed to illicit fentanyl. This is just one case study from British Columbia where people who thought they were smoking crack were actually exposed to fentanyl and fentanyl analogs. There have been cases in the US as well. And then we see a proliferation of counterfeit opioid tablets, Percocet, oxycodone, et cetera, that are actually pressed fentanyl. And given the unpredictability in the drug supply and the potency of synthetic opioids, it is a serious concern of who all is now at risk in the universe of people who are using substances. And lastly, I'll just say, getting to the policy side and hopefully setting up the rest of the speakers, is that we have to look at this issue comprehensively. And fundamentally, we're in the situation that we're in because there was this massive increase in opioid prescribing that started in the mid to late 90s, and much of it done not maliciously. Individuals thought that we can apply what we know around opioids in cancer pain or palliative care, and we can have good outcomes for people who have chronic non-cancer pain. We now know that's really not the case, and opioids are probably not the best option for many types of chronic non-cancer pain. We also saw people prescribing at higher doses, longer durations of time, and in combination with other drugs like benzodiazepines that can increase risk. And as that has happened, we now have this growing cohort of people who are addicted who really don't have access to high-quality evidence-based addiction treatment. And until we address both of those issues, as well as coming up with better ways to treat pain, the 25 million people who have daily pain, we're not going to have a really long-term solution to this problem. So thank you very much.